Alrighty, here we go. Hello everyone, and thank you for watching this program and coding for headaches, rib conditions, and extremities. There's no audio taping or videotaping, and then any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information in this presentation is for educational purposes. It does not substitute your thorough clinical decision-making and should not be construed as a written policy for any agency. It's not intended to be legal advice. Target coding does not engage in providing legal services. If I mention CPT codes, that's a registered trademark of the AMA. I've made every attempt to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Just a little bit about myself before we get going. My name is Dr. Marty Kotler. I am a chiropractor. I am certified in CPT coding. I'm a certified professional compliance officer. My areas of expertise include E&M, that's evaluation and management, coding and documentation, CPT ICD10 code pairing, compliant cash plans, how to manage care, and HIPAA compliance. I've written 10 compliance and documentation training manuals. I'm a featured speaker for the Coding Institute, Parker Seminars, Foot Levelers. I write articles for Chiropractic Economics and Dynamic Chiropractic and many other state association newsletters throughout the country on chiropractic billing, coding, compliance, and documentation. Plus, I'm a guest speaker at many state association conventions nationwide. I have a whole bunch of guest speaking opportunities coming up throughout the country. Hopefully, you'll come see me at one of these events. Come up and say hi. All right, so let's begin with our first set of ICD-10 codes on headaches. So let's start off with migraine headaches. So when you look at migraine headache codes, let's take a look at the first one, G43.001. That's migraine headache without aura, not intractable, with status migrainosus. So let's break that down because there's a lot of terms in there that you may not be familiar with. So to begin with, migraine headache, pretty common. It's typically on one side of the head, and these items you see in the description of the code, you can start to determine whether the patient has these items just by talking to the patient without actually having to do a physical exam. For example, Mrs. Williams comes in and she says that she has headaches, typically on one side of the head. So you're starting to narrow it down based on what the patient's telling you, that she has migraine headaches versus tension or other types of headaches. Or she might just tell you, I've been to many doctors and I have a diagnosis of migraine headache. So now, aura. What is aura? That's something you can determine just by talking to the patient. So this particular code, the first one here, is without aura. So my recommendation when you're doing your consultation with Mrs. Williams is to say, Mrs. Williams, I want to ask you about, before you feel the actual headache, do you feel like, you have some confusing thoughts or strange smells, or you see, you have a sensation of seeing sparkling lights, you have some visual changes? Do you experience that prior to the headache coming on? The patient says, yes. How did you know that, Dr. Kotler? Then that's going to be with aura. We didn't get to those codes yet. All of the ones you see on your screen right now are without aura. The patient says, no, I don't experience any of that. The headache just comes on suddenly. So now you're looking at without aura. Next, intractable or not intractable. What's that? You'd be surprised as to how many doctors and staff members that I speak to that do not know the difference between intractable or non-intractable. So again, you're having your consultation with Mrs. Williams, you're doing the history. You should ask the patient, have you done anything for your headaches? If the patient says, yes, I've tried certain things and they help. I've tried massage, I've tried heat, I've tried some over-the-counter medication, and it does provide some relief, but it's not that long-lasting. So that's considered not intractable. If the patient says, I've tried everything, nothing seems to work, the patient fails to respond to conventional methods, then that's considered intractable. So you could ascertain that just by talking to the patient. Next, status migrainosus. Again, I speak to hundreds, maybe thousands of chiropractors a year with all the presentations that I do throughout the year, and most chiropractors and staff members do not know what status migrainosus is. So a migraine headache that lasts for more than 72 hours is considered status migrainosus. And this is a situation where the patient's headache has gotten so bad they need to be hospitalized and possibly put on IV medication. So that's another thing that you could ask during the consultation, during the history, ask these questions, so then you could start narrowing down which of these codes you're going to use. Now there are many, many more headache codes. I'm just providing you with a few here because we only have a short period of time here together, but these aren't all of them. This is a condensed list. So then we go to G43009. The difference here is this is without status migrainosus. Next, G43.011, migraine without aura, intractable with status migrainosus. G43.019, migraine without aura, intractable without status migrainosus. Next, we have G43101, migraine with aura, not intractable with status migrainosus. G43109, with aura, not intractable without. G43.111, migraine with, intractable with. G43.119, migraine with, intractable without status migrainosus. So there's those are 8 migraine codes that you should add to your, I call it like a cheat sheet or a quick guide or a favorite list. I recommend you add those 8. Again, there are many more. I would narrow it down to those 8. But you could go and take a look at the full list. Now let's talk a little bit now about tension type headaches, and traumatic type headaches. So we have G44. As you could see, the headache codes all begin with the letter G. So G44201, tension headache, intractable. 209, not intractable. 221, chronic tension type headache, intractable. 229, chronic tension type headache, not intractable. Now, for those of you that see personal injury patients, you might want to consider using some of these codes, or any type of trauma. Now we have trauma codes here, post-traumatic headache codes. Now, typical traumatic codes or injury-related codes, those begin with the letter S. S is in subluxation. But here we have a few that don't follow the pattern. These are acute post-traumatic headache codes, G44.311. So you may have a patient that comes in and says, hey, Dr. Kotler, I was in an automobile accident. After the accident, I started to get neck pain, and then a few weeks later, I started to get, immediately following the accident, I started to get headaches that would be more in the acute category. Even if the patient developed headaches a couple of days after the accident, where they didn't feel it initially, I would still go with the acute. So that's 311, acute post-traumatic headache, intractable, not intractable. Again, what is the patient doing to help the situation? If nothing's working, that's intractable. If something the patient's doing, some response, that's not intractable. Then we have chronic post-traumatic headaches. G44321, intractable. 329, chronic post-traumatic headache, non-intractable. So there's a bunch of migraines, tension, traumatic codes. Now we're going to switch to jaw-related codes. Many doctors I work with treat, adjust the jaw joint. I have a few clients that are experts in AK and SOT, and they do a lot of jaw work. I have a few clients that have developed relationships with dentists where they're getting most of their new patients from dentists because of their expertise in treating the TMJ. So here's a whole bunch of codes here that you may not be familiar with that you can use in a typical chiropractic practice. M26.51, that's abnormal jaw closure. M2652, limited mandibular range of motion. 601, temporomandibular joint disorder on the right side. We have two, right? So we have TMJ disorder on the left, that's 602, and if the patient has bilateral TMJ disorder, that's M26.603. How about just jaw pain, mandible maxilla pain? That's in the R section of codes, R68.84. Sprain of jaw on the right side, S0341, left 42, bilateral 43. How about strain of the muscle and tendon of the head? Anything related to the head or the jaw hair I thought I would put in this presentation. That's S09.11. Now, when you see the X, don't worry about, that's a dummy placeholder, but there is a dash under the S codes. S codes, like I mentioned a few minutes ago, relate to trauma, relate to an injury. So you have sprain, strain, there are fractures, contusions, traumatic brain injury, even traumatic subluxation codes. Those all begin with the letter S. Whenever a code begins with the letter S, you must have a 7th digit extender. That means an A, a D, or an S. A means initial encounter. D means subsequent encounter. S means sequela. We don't have time to get into those today, but that's why there's a space at the end of the S codes for you to place the proper 7th digit extender in there. All right, let's switch gears now to rib codes. Many of the clients I work with, they go, hey Marty, I have patients coming in with all these rib problems. I can't seem to find any good rib diagnosis codes. Well, there aren't that many, but I've narrowed it down to a few here that would probably pertain to your practice. S23.41, that's a sprain of the ribs. S23.42, sprain of the sternum. S23.420, sprain of the sternoclavicular joint or ligament. Here's a good one. Get this question quite often. What's the diagnosis for costochondritis? And that's what I get, I have clients all over the country, and I'll get, simple questions from staff. Hey, Dr. Kotler, what is the diagnosis? What is the ICD-10 code for costochondritis? Hey, Dr. Kotler, what 7th digit extender should I use on the sprain of the sacroiliac joint? I get all these simple questions, but that one I get quite often. What's the diagnosis for costochondritis? In chiropractic college, you may have heard the term tsetse syndrome, so that's M94.0. And then we have segmental dysfunction of the rib cage, or you could interchange that term with subluxation. And then we have M99.19, that's the subluxation complex, different than segmental dysfunction. And then M99.88, other biomechanical lesions of the rib cage. There's a few good rib diagnosis codes. Another common question I get is, any good diagnosis codes for the sacroiliac joint? A lot of chiropractors treat that. It's very common. And the sacroiliac joint is oftentimes confused by patients. Many patients will come in and say, I have hip pain, and oftentimes I would tell the patient, okay, Mr. Jones, stand up, turn around, and point to your pain. Now, Mr. Jones said, I have hip pain. He goes, I have left hip pain, and Mr. Jones is really, when he stands up, he's pointing to his SI joint. And staff members, if you're involved with the doctor in the consultations and maybe even the exams, the sacroiliac joints are those, if you ever look at somebody from the back, maybe, at a pool or a beach, you see two dimples in the lower back. Those are the locations of the sacroiliac joint. It's the joint of the sacrum and the ilium, the pelvic area. So it's a pretty common area that patients will have pain. Again, when a patient comes in and says, I have hip pain, have them stand up and point to where the problem is. Very rarely, when I hear a patient say I have hip pain, they're actually pointing to the hip, to the acetabulum or the femur, that joint. They're typically pointing to their lower back area and the sacroiliac joint. So it's a common area for problems and osteoarthritis and subluxations. So here's a few SI joint codes. M46.1, sacroiliitis, non-elsewhere classified. M53.2X8, spinal instability of the sacral and or sacrococcygeal region. M54.18, radiculopathy, sacral and sacrococcygeal region. And as far as radiculopathy goes, I just did an excellent webinar on how to diagnose cervical and lumbar radiculopathies, and I provided a whole bunch of cervical and radiculopathy diagnosis codes, and I provided the clinical rationale. So go ahead and take a look at my target coding YouTube channel, and you'll see that nice little webinar on radiculopathies. We got M99.04 sacral subluxation, 05 pelvic subluxation. According to the American Medical Association, which owns the copyright on the codes, the SI joint is considered the pelvic region, not the sacral region. Very important when you are billing a 98941, verse 40, verse 42. That's a good one right there. S33.6, sacroiliac sprain. Again, S codes relates to trauma, some sort of injury. It doesn't have to be an automobile accident. You could have Mrs. Williams standing on a ladder, and she's changing a light bulb in her house, and she falls off the ladder, and she sprains her sacroiliac joint. So there's a trauma code that you could use, injury-related code that has nothing to do with workers' comp or an auto accident. And then we got S33.8, sprain of parts of the lumbar and pelvis. Remember, make sure you know the difference between sprain and strain and how to diagnose that and substantiate it. Quick difference, sprain relates to ligaments, strains relates to muscles, but you need to do certain ortho and neuro tests, in my opinion, and chiro tests to determine the difference between the two so you could justify it, especially in auto accidents where you may have to appear in court or in a deposition. S39.012, muscle strain of the lower back. S39.013, muscle strain of the pelvis. Now I mentioned, make sure your documentation could support the codes you bill. Let me touch a little bit here on ICD10 and documentation. With ICD-10, the clinical documentation had to get kicked up a notch because the ICD-10 codes are more specific in general. Most of them are more specific, so your documentation must include a level of detail that can support the increased specificity required, and this increased specificity may require a new roadmap for some providers that are not used to documenting with this level of specificity. So yeah, let me give you an example of that. Mr. Jones comes in with a problem in his sacroiliac joint, a sprain, sacroiliitis, something to do with the SI joint. So let's say it's a sprain, S33.6. That's your diagnosis. That's what you are reporting. Now we're talking about even with a cash patient, this is important. Yes. Why would this be important with a cash patient? Cash patients can sue you. Right? Cash patients just file a complaint against you with the state board. So with those two situations, even if it's a cash patient, your documentation must support the diagnosis you come up with. Yes, even cash patients. So you diagnose a patient with a sacroiliac sprain, and now your question, whether it's an insurance company, auto accident case, you're on the witness stand, a malpractice case, state board, and they go, well, Dr. Kotler, we see that you diagnosed this patient with a sacroiliac sprain. How did you come up with that? What did you do to justify that? So hopefully you have a good answer. Hopefully you'll say, well, the patient had pain in the SI joint, and we did some ortho tests. We did Yeoman's, Ganslin's. I mean, there's a whole bunch there. You don't have to do all of them. Yeoman's, Ganslin's. Listen, I could tell you, Yeoman's, Ganslin's, Faber-Patrick, those are the gold standard orthopedic tests for any type of SI joint. So it would be a good idea, right, to do those if you're going to diagnose a patient with some sort of SI joint problem. Now you might say, well, Marty, I don't do ortho tests, I don't do neuro tests, I don't own a reflex hammer, I don't own a stethoscope. That's not what I do. I'm subluxation straight, chiropractor. Okay, I think it's a little risky if you ever get have an issue on where you have a state board. They're tough. So it behooves you to do a couple of these ortho, Yeoman's, Ganslin's, chiro tests, SI joint, palpatory tenderness, edema, subluxation. It could come up with other things like cervical brachial syndrome. Do Wright's, do Atson's, do some reflexes, check for diminished reflexes, check for myotomal weakness. This will save you if you're ever in trouble by doing some of these ortho, neuro, chiro tests. And actually, I'm going to mention a book in a few minutes that it's an excellent book that I recommend all chiropractors have as part of their library, where it provides you with a whole bunch of very common chiropractic diagnosis codes, and then it also provides the ortho, neuro, chiro, subjective tests to do in order to justify that code. Alrighty, let's move on now to extremity diagnosis codes. Extremity codes. Start with the shoulder. Yeah, pretty straightforward. You got right shoulder pain M25.511, left shoulder is 512. Now I know I'm going to get this question, Dr. Kotler, what happens if the patient comes in with bilateral shoulder pain? What's the code for that? Well, at the present time, there ain't one. So I guess you'd have to report both. Shoulder stiffness, that's pretty common, M25-611 on the right, 612 on the left. Adhesive capsulitis on the right, M7501, left, M7502. So you can see the pattern with extremities. The right side is designated by the number 1. The left side is designated by the number 2. Let's move on over to elbow codes. Pain in the right elbow, M25521, left 522. And then we have medial epicondylitis. Medial epicondylitis, that's also known as golfer's elbow. I've heard some people call it suitcase elbow, baseball elbow. That's medial epicondylitis. On the right, it's M77.01. On the left, 02. And then we have lateral epicondylitis. That's more common out of the two. Lateral epicondylitis, also known as tennis elbow. But I could tell you, most of the patients I treat that come in with lateral epicondylitis do not play tennis. It could occur from many other activities. So lateral epicondylitis. On the right side, M77.11, left side, 12. Got some hip codes for you. Pain in the right hip, M25551, left 552. Bursitis, that's pretty common. Patients come in, I got bursitis in my hip. My medical doctor told me I have bursitis. So there you go, M7071 on the right, 72 on the left. Strain of the hip muscles, here we go. Strain of hip muscles. You see strain relates to muscles. There's an S code, trauma, injury related, and you need to use that 7th digit extender. Strain on the right, S76.011, left 012. Couple of knee codes. Pain in the knee, M25561 right, 562 left. Patellar tendinitis, M7651 right, 52 left. Quadricep strain, sure, pretty common, especially those of you that treat a lot of athletes, runners. I have a client in Virginia. Man, 99% of his practice are runners. He sees a lot of knee problems, a lot of extremity adjusting. Doing great. S76.111 on the right, strained quadricep on the left, S76.112. Anterior cruciate, now we get into ligaments and we get into, post-surgical. I have a client right now booming with post-surgical care. Not only is he booming with his chiropractic practice on post-surgical care, now he's brought in a physical therapist, which has doubled his practice because he's getting a lot more referrals for his post-surgical situations by Ortho, sending him tons of patients. Sprain, anterior cruciate on the right, S83.511, left 512. Now, this is just a small sampling of extremity codes. Knee codes, there's probably 100 different types of knee codes. I'm just narrowing it down here. Comorbidities and complicating factors. These can impact the plan of care. That's the key thing right here. Comorbidities and complicating factors, if they're impacting the plan of care, then you should include it as part of your overall approach. If it's not impacting the plan of care, then I guess you don't have to make a big deal about it. For example, if the patient has diabetes, but it has nothing to do with what they're coming in with, then it doesn't impact the plan of care. However, if it is impacting the plan of care, then I would recommend you have that as part of your documentation and you list it as a reason why the patient needs more care. There's type 2 diabetes right there on your screen, E11.40. Again, there's tons of diabetes codes. Insipidus, diabetes mellitus, with diabetic neuropathy, without. Just giving you one example right there. Overweight, E66.3, F41.8, anxiety, depression, and just look about it. Look at it this way. Mr. Jones comes into your office. He's got back pain. That's it. Next, Mrs. Williams comes in. She's got back pain, but she's also overweight and is taking medication for anxiety. Mrs. Williams is probably, not definitely, probably going to need more care. Sleep disorder, G479, chronic fatigue syndrome, very common, R53.82, just lack of energy. Patients complain of that all the time. I have a client, he specializes in functional medicine. This is all he does is he treats chronic fatigue, fibromyalgia, this chronic muscle weakness, generalized muscle weakness. Hey, that's a diagnosis I don't have on the list, but generalized muscle weakness, that's what he specializes in. He doesn't treat back pain. He doesn't really treat neck pain, the typical things people go to chiropractors for. Osteoporosis, of course, that could relate to, you can consider it a complicating factor, M81.0, osteoporosis, age-related, without pathological fracture. There are many osteoporosis codes with fracture. So here's just a few comorbidities and complicating factors. These conditions in and of themselves might not constitute the need for chiropractic, but these conditions superimposed on your typical chiropractic conditions will increase the need for more care. And you could use these when you're dealing with certain health plans that want you to put together a medical necessity in advance to justify the codes. So you should use these if they're impacting the plan of care. Alrighty, now here's a bunch of other codes that we just don't have time to get into, and the book that I mentioned earlier have these ICD-10 codes listed in a nice format, but these codes definitely relate to chiropractic: reverse cervical curve, abnormal posture, piriformis syndrome, torticollis, iliotibial band syndrome, ligament laxity, psoas tendinitis, carpal tunnel syndrome, tarsal tunnel syndrome, neuralgia, neuritis, postural kyphosis. I have a client, that's his deal. 99% of his patients is reverse cervical curve, postural kyphosis. It's, ligament laxity, abnormal posture, that forward head carriage. That's what he specializes in. These are great. Some of these are great for him. Bell's palsy, tinnitus, myofascial pain syndrome, occipital neuralgia, dizziness, cervical rib, frozen shoulder. I have a client, all he treats is baseball players. He's dealing with shoulders all the time, every day, all day, shoulder problems, rotator cuff syndrome, congenital fusion of the SI joint. So these are excellent chiropractic related codes in my opinion. Just a few closing comments here. Just about done. Please check with all the carriers you bill prior to submitting claims based on this information. We can't guarantee that this information will guarantee payment from any health plan or patient. Target coding is not responsible for any insurance carrier, managed care organization laws, rules, guidelines that may change. You know they change all the time. Stay on top of these changes. Attend seminars. Attend webinars. Join your national and state professional associations. Here's our contact information. Before we get to questions, I just want to go over a couple of things with you. The book that I was referring to earlier that provides you with these diagnosis codes in a nice simple format with quick codes and cheat sheets and long-term codes and short-term treatment codes. And the justification is in this book. It's called The Best Chiropractic ICD-10 and CPT Codes to Improve Reimbursement. Learning how to bill and code isn't expensive, but neglecting it and defending it, yeah, that could become very expensive. I like that little tagline there. So this book in chapter 3 of the book, it lists certain diagnosis codes, like if you're going to diagnose a patient with a cervical radiculopathy, do some ortho neuro tests. I'm telling you, it'll save you in the long run. It might not be something you want to do because you could be in practice 20 years. Just by looking at a patient, you can come up with a diagnosis. I know that. Many of you have, are really good at that. You could be in practice 25 years. Just by talking to a patient, you can come up with their diagnosis. However, if you're going to treat the patient, even if it's a cash patient, you should do a couple of these things. Cervical radiculopathy, check reflexes, check for myotomal weakness, Jackson compression, Valsalva, you remember that? Sperling, shoulder depression. If you're not familiar with some of these orthopedic tests like Wright's and Atson's or upper limb tension tests, very simple nowadays. Just go to YouTube and type it in. You'll see a nice little video. And there's sprain and strain. So this book gives you some really good information. Here's quick guides. This is for personal injury patients. What are the best PI codes for the neck, mid-back, lower back? Frequently asked questions. Again, some of my clients in practice 10, 15, 20, 25 years, they are not able to tell me the difference between cervical brachial syndrome and cervical radiculitis. They don't know the difference between myalgia, myositis, and myofasciitis. They can't tell me the difference between effusion, swelling, and edema. They have no idea what the difference is between a disc disorder and a disc displacement. So this is a nice book. Oh, here's another excellent item in the book. It shows you how to pair your codes. You know how you pair food and wine? Oh, okay, I'm going to have some red wine with my steak tonight. Yeah, I'm going to have white wine with my fish. Okay, well, this shows you how to pair your CPT codes to your diagnosis codes. Here's an example. Therapeutic exercises. What are the best diagnosis codes to link or pair with therapeutic exercises? There you go. Oh, also, this has become a big deal lately. Most states require an OIG Compliance Manual. If you treat Medicare patients, you must have an OIG Compliance Manual. So we've put one together for our clients. It's Target Coding's OIG Compliance Manual. It's very simple. It's about 25 pages. It handles all the key components of an effective compliance plan that the federal government has put out. You get a customized OIG Compliance Manual. You get policies and procedures, personalized for your practice. We give you a chart audit tool so you can do your own internal evaluation of how you're doing with your documentation. The purpose of an OIG compliance plan is to prevent billing and coding errors. So if somebody comes knocking on your door and says, Dr. Kotler, what steps do you take? Do you take any action steps? Could you prove to us what you do to prevent billing and coding errors? Now, if you say, well, we go to seminars, yeah, we have trainings, it's not going to work. Is it in writing? Do you have a policy and procedure on it? if you have a staff member that all of a sudden gets in trouble for stealing information from your practice and now is committing insurance fraud, do you have a policy and procedure on that? We have sample training logs, incident report forms, employee attestations. So we recommend, and if you don't get one from us, get one from somebody. If you're treating Medicare patients, any federally funded program, it's mandatory. It's not optional. It's mandatory that you have a compliance manual. Here's our chart audit tool. It's in an Excel spreadsheet. It's just, boom, did you do this? Did you ask the patient this question? Do you have the patient's name on every page? Do you have the date on every page? Did you sign the note? Do you have a diagnosis code? Do you have a CPG code? Do you have a subjective? So it's a nice little checklist. Oh yeah, HIPAA. HIPAA is also required. Those of you that are listening to this from Florida, HIPAA is mandatory. According to Paul Lambert, very well-known attorney for the Florida Chiropractic Association, HIPAA is mandatory in the state of Florida. It's actually mandatory in all 50 states. So we offer a HIPAA compliance program. Now this, this is complicated. This would be very difficult. An OIG compliance plan, you could probably, maybe if you spend about, 10 hours, you could probably do it yourself, OIG. HIPAA, it's probably 100 hours. If you were going to try and create, like if you're the type of doctor that you submit your own taxes and you said, you know what, I'm going to tackle this, I want to do this without hiring anybody, it would probably take you about 100 hours to put together your own HIPAA compliance program. Yeah, it's very comprehensive. It's a behemoth of a program. But we've figured it out to narrow it down. If you work with us, we could probably get it done in about 10 to 15 hours. So our HIPAA compliance program is very comprehensive. You get a security risk analysis, which is mandatory now for your MIPS program, your Medicare MIPS program, through the incentive money. Security risk analysis is mandatory. You get a cloud-based storage portal, so you could upload all your policies and procedures into this cloud-based storage portal. You could access it from anywhere in the world at any time. You have complete control over it. At any time you could extract all of it, download it, print it. I have one client that I'm going through the HIPAA program with. He wants everything hard copy. He's just, more old school, wants everything on paper. So he's got the best of both worlds. He's got his 3-ring binder with all the papers on his desk, and he's got the information in the cloud that he can go and get at any time. We have compliance training videos for all your staff members. If you want to take a little test, you can get a nice little certificate. You can print it out, put it on your wall. We help you track your business associates. The HIPAA program includes OIG. OIG does not include HIPAA, but HIPAA includes OIG. You get updates and $100,000 of cyber liability insurance, and that's what HIPAA is about. It's all about cyber liability. We have a whole bunch of seminars coming up. Check our website for our seminar schedule. We offer memberships. This is our basic membership. You could stop and start whenever you want. Gold membership is a 1-year program. Platinum membership includes an on-site visit. We have an opportunity for you to just talk with us for 15 minutes just to see what's going on. Hit us with questions. 15 minutes could help you collect an extra 15% or more. Call, email us, let us know if you're interested in this. Again, here's our contact information, email info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. Our HIPAA secure fax number is 1-844-831-2347. I want to thank everybody for attending. I hope you learned a lot.